I've had experience now with over 200 Heller myotomies, and been doing it for a long period of time. And I've seen a lot of different issues over the years, and I've worked out a way to manage, I think, most of them without having to reoperate on these patients the vast majority of the time. So, Heller myotomy. I mean, the key to a Heller myotomy, of course, is to make sure your selection criteria is proper to begin with. So all of these patients have the usual testing, but especially a motility test to show that they have absent peristalsis, which is, of course, pathognomonic of achalasia. The procedure itself is pretty straightforward now. You need a long myotomy. The key here is to make sure that it is onto the stomach wall. There is no exact number of centimeters onto the stomach wall that it has to be, but we do know that it has to be at least 1 to 2 centimeters on the gastric wall. The longer on the gastric wall, the more likely you're going to have reflux, of course. The proximal portion of the myotomy is done as far up as you can reasonably go. It usually ends up at about 8 centimeters or so of a myotomy. And once again, there's no randomized prospective trial to show exactly how long it needs to be, but you need to complete the myotomy. What I've found over the years is that the easiest way to tell that is to have an intraoperative endoscopy at the same time, because sometimes it's very, very hard to know exactly how far on the stomach wall you are, especially if there was a hiatal hernia associated with the achalasia. So I use intraoperative endoscopy 100% of the time. The side benefit, of course, is that if you've made a entry into the mucosa, you'll be able to identify it and close it at that time. So the imaging study I do is that I keep the patient overnight and do a gastrograph or barium study postoperatively on day 1. And that will confirm that the esophagus empties. It's always a little bit swollen because of the partial fundoplication that has been performed. And by the way, we're not going to get into the various types of fundoplication that are possible. My preference is sort of a modified door, but we can talk about that at another date. I do the study, the contrast study on day 1 to make sure that the esophagus empties, and that, of course, it confirms that there is no entry into the mucosa. I start the patients on liquids the night of surgery, assuming that their vital signs are stable and the surgery itself went well. If I had made, which is less than 1%, but if I had made an entry into the mucosa, I would keep them at NPO until I confirmed that that there was no leak. So I want to tell you a little story about the second patient that I operated on, who happened to have been a policeman, and I operated on him in the morning and made my afternoon rounds in the evening, and I asked him how he was doing, and did the liquids go down fine? And he said, "What liquids? My wife went out and got me a hamburger, and I had a hamburger 4 hours, 5 hours post-operatively, and it went down great." So it taught me a little bit of a lesson that you can really be a little bit more aggressive if you want in terms of diet, but I think that the smartest thing to do is to keep people in liquids until you confirm that everything is okay. But that means that post-operatively, you don't have to keep patients on liquids for 48 hours, 72 hours. I let them eat. Of course, I tell them to go very, very easy, and I tell them to avoid the same things that gave them trouble preoperatively. That's usually bread, white meat chicken, white meat turkey, well-done meats, things of that nature that are, in general, hard to get down. Bagels also famous for being difficult to get down. I tell them to avoid that, but I let them eat, and as they feel, as they feel like they want, assuming that the post-op contrast study is okay. So I think there's a lot of mystique about diet post-operatively, but I'm pretty aggressive about letting them eat. I do caution them against bones, chicken bones and fish bones, but I've yet to have anybody have that issue. So I learned early on that if you don't put a patient on PPI postoperatively, that they can narrow their lower end of the esophagus from a peptic stricture. And at the beginning, I did put people on PPIs, and I had a couple of people after about a year or two came back with symptoms of achalasia that were exactly the same as as the symptoms they had before I operated on them. And I knew that I had done a complete myotomy because their dysphagia was gone. Their dysphagia scores were 8, 9, or 10 postoperatively, knowing that the myotomy was complete. And then they came back with recurrent symptoms. So whenever you see someone you've done the complete myotomy, the dysphagia is gone, and then they come back, you can bet that it's going to be a postoperative peptic stricture. I never say 100% of the time, but close to 100% of the time. And they get dilated, and then they stay on PPIs for the rest of their life. So now I've changed, and over the last 10, 15 years, I place every single patient on a PPI or an H2 blocker. Actually, I usually use H2 blockers to begin with instead of a PPI because it's over-the-counter and cheaper, and tell them to take it as stated on the box, especially at nighttime. Because when the patient is lying flat, that's when their esophagus gets bathed with acid or enzymes from the stomach and can cause the stricture. I haven't had very many of them, but I haven't had any lately because I'm very, very careful about making sure that the patients are compliant with taking PPIs. And they have to be told that multiple times because most of the time they feel so well compared to what they did preoperatively that they think that that's the end of the story, but clearly it's not. Peptic stricture occurs, I would say, at about 2 to 3, maybe even 4% of the time postoperatively if you've done a complete myotomy. Because after all, what have you done? You've destroyed the lower esophageal sphincter and you really have a free conduit for reflux. Patients who have achalasia don't have the same sensitivity of the lower end of the esophagus that normal people do. So they can actually be refluxing a lot and you don't know it, or they don't know it. It's one of the reasons why really postoperative 24-hour pH study is a really good thing to confirm exactly what's happened with the myotomy that you've performed postoperatively. I think that's an important consideration. Otherwise, the patients, by and large, do very, very well. Assuming that your myotomy has been complete. The other thing I would say that I think is important is that when you're doing the intraoperative endoscopy, it's important to have a person who you're used to doing the endoscopy that looks at it and they're used to interpreting exactly what they're looking at because it's possible to get some really spurious information on intraoperative endoscopy if you're not used to the person who's doing it. Of course, the surgeon can do it, but the surgeon's doing the endoscopy. It's hard to look on the outside and be 100% sure if you're doing the endoscopy and you're looking from the outside on a video system. So it's good to have a team effort with that. And if you follow all these things, the patients, by and large, will do very, very well. You also have to caution the patients in terms of needing intraoperative endoscopy, at least, if not every year, every couple of years, because of the incidence of a carcinoma of the esophagus in this disease. I have not yet had one, but statistically, it is certainly higher than the general population, and that's something that needs to be conferred to the patient for postoperative problems. And that's my take on postoperative issues with achalasia.